Esteemed moderators, distinguished delegates, dear friends, I am really proud and privileged to be a part of this wonderful symposium named in the honor of Dr. J.C.M. Shastry, who is a wonderful teacher and a fine human being. Now, no talk on nephrology will be complete without paying respects to father of nephrology, Professor K.S. Chug, who took nephrology outside Patiala to Vellore, and he did his first biopsy in Vellore. We have three important doyens in nephrology sitting in the audience. My mentor and teacher, Professor M. Muthusedu sir, Professor M. Thomas Matthew sir, Kashi Vishweswaran sir, who had always been an inspiration for me for carrying my work in nephrology. Now going on to my focus in Kerala, how did it start in Kerala? The first nephrology service effectively was started by Dr. Patros Mathai in Kottayam in 1972, followed by Professor Thomas Matthew sir, who started nephrology service along with dialysis in Medical College, Calicut. And then it was followed by Professor S. Krishnakumar, who started nephrology division in 1981, but he did biopsies as a part of his MD medicine thesis in 1967. Kashi Vishweswaran sir started his nephrology unit in Kottayam in 1981, and Georgie Nayanan was credited for the first cadaver transplant in 1989 at Cochin. Now moving on to the timeline, though coil dialysis was procured by Dr. Ramachandran in MCH Trivandrum and by Thomas Kurian in Tiruvalla, it did not bear fruits, they could not carry it further. The first effective dialysis, as I have already shown, was done by Patros Mathai sir, followed by Thomas Matthew sir, Kashi Vishweswaran sir, etc. And in government setup, the first transplant was done by Thomas Matthew sir and team, along with Dr. August Chali in 1986. Ramdas Pisharji started transplant in Trivandrum, and myself, after my fellowship in US, started the first CRRT at Kottayam in 1998. Now, what is the current status of nephrology service? Today, there are around 22,993 hospitals giving nephrology services. In and around Trivandrum district, we have 20 hospitals offering nephrology dialysis service. Kerala has several nephrology outpatient, inpatient services dialysis. All centers have RO water. Most of the centers now have HDF machines, CRT procedures being done. Transplant and postgraduate teaching programs are effective. DM has been started in 6 medical colleges, first started in Calicut Medical College. We have more than 7 hospitals offering DIP and B in nephrology. Now, what do you understand by equity in medical care? That is, everyone has an opportunity to attain the full potential of health. That is what you understand by equity. No one is disadvantaged from attaining this potential due to race, ethnicity, age, disability, socioeconomic status, sexual orientation, nationality, etc., etc. It focuses on fundamental justice. So what is the goal? You have to make this practical. So though we know that all cannot afford this, so it requires giving some people more support and resources. How is this achieved in Kerala? This is implementation through some governmental programs. There are 3 main programs by government of Kerala. One is Samaswasam scheme. Second is the Karanya Benevolent Fund. 3 is the Ashwa scheme. As we see, the Samashwasam scheme gives only 1,100 rupees per month. At least they should do only 1 dialysis per month. They get only 1,100 rupees. Peritoneal dialysis has been started. Our minister has announced recently that every major hospital and district will have a free peritoneal dialysis service. The Karanya Benevolent scheme was very active. This was an assurance scheme of the government. This includes many chronic diseases, including CKD. Funding is raised from Kerala Lottery. Financial assistance to underprivileged people, maximum of 3 lakhs. Application procedure is very simple. You can apply with a ration card, income ration card through a IT procedure. The amount for dialysis is 900. The Ashwa scheme was started during the COVID period. This was scheme by the Panchayat in Trivandrum district. Total of 36 dialysis units, 5 dialysis per month. They give 900 per dialysis directly to the hospital. We have the Government of India equity programs, as we all know. The PMNDP program. In Kerala, 14 districts are covered, 103 dialysis centers. The maximum amount is 1,25,000. Ayushman Bharat Pradhan Mantri Arogya Yojana scheme, that also gives the same amount. Now, we understand that there are so many governmental programs, there are NGOs also, but this is not the final thing. There is a high cost of treatment. Medication to treat renal disease is highly expensive. Even if they procure medicines, the governmental agencies cost around 8,500. Only around 25% of the ESRD population has access to government centers. So the 75% remaining are in private sectors. So there is a study which was done by Noble and group. They studied the impact on families who are undergoing maintenance hemodialysis. They concluded that households with patients on maintenance hemodialysis in Kerala experience crippling level of financial hardship related to treatment despite availability of a variety of medical subsidies. Given the significant psychosocial and financial ramifications of ESRD diagnosis in resource-constrained settings, government and healthcare providers must work together to develop sustainable strategy to provide equity. That was the conclusion. So now that takes me to the third part of my talk. How do we empower nephrology services? We know that kidney disease is 1 in 8 worldwide. 2019, 3.2 million deaths reported. Equal number reported through acute kidney injury or not able to access the ESRD service. So the death rate must be much more. It is ranked at 7th the global risk factors for death. This is due to lack of reporting. We are not able to report our data, and there is a holistic view that once you are diagnosed with chronic kidney disease or creatinine of 2 milligram, the answer is dialysis or transplant. Nothing you can do about it, and there is no effective treatment. Now, how do we change this? How to empower equity and quality of chronic medical care? CKD remains asymptomatic. Silent screening is important. Create awareness. Only 1 in 5 are aware of their diagnosis globally. Stress on preventive nephrology. Requires equitable and sustainable access to health care. Now, in a study conducted by us in 2009, only 16.9% of the population was aware of hypertension. But in 2022, as you see, the awareness has increased to 23.9% in men and 51.2% in women. So it's still far from what we would expect, but then there's a tremendous improvement in awareness. In Swartz family cohort study, again it was 56.2 in women and 62.2% in men. So we have to create awareness. Lack of awareness in diabetes is also there. People think that diabetes is usually familiar. When we try to tell them, my father had diabetes, my mother had diabetes, I can't do anything about it. So we should educate them with lifestyle modification. Only low proportion of diabetic patients know that can affect multiple organs. Alarmingly low proportion of patients also know that diabetes can be prevented even if there is a familial history by modifying their lifestyle. Now, there is I wouldn't blame anybody, but there is a lack of awareness in health professionals as well. Most of them are not getting monitored for their urinalysis not being done, creatinine not being done. So we should educate our health professionals that in susceptible patients at least, we should do a need for urinalysis, which is a non-invasive biopsy of the kidney, creatinine GFR at least once in 6 months, and we should judiciously prescribe our medications knowing what we are prescribing. Now, how do we empower? To empower nephrology service, education programs to create awareness on predisposing factors, community screening programs for people above 30 years, school children to be educated about the need for diet, exercise, avoidance of alcohol, drug abuse, debunk the myths that is drugs from modern medicine do harm, OHAs affect kidney, drugs from other systems of medicines are safe, does not affect the kidney. We should educate them well. So what are the research areas to improve? Community screening programs for early detection of predisposing conditions like diabetes, hypertension, injudicious medications of Ayurvedic or NSAIDs, detection and management of UTI in children. We should evolve new therapeutic strategies. So to evolve new therapeutic strategies, we should have a better understanding of the etiopathogenesis and pathology. We have to build confidence measures and awareness. CKD is a highly manageable condition. There is a gap between the knowledge and the delivery. So we should be able to educate the public that kidney disease diagnosed early, there are various measures which can prevent the progression of the disease. It does not equate to dialysis or transplant, till you can do much more things for the prevention of progression. So call for action is advocacy, research, and improve equitable access to sustained medical care, quality care. So I would conclude my talk on this evolution by paying my respects and fond remembrance of Dr. Patros Mathai, who has been instrumental in starting nephrology in Kerala. my own colleague and friend, Professor Ramdas Pishardi, whose brainchild was the Matasanjeevani program, and my friend, Dr. Lekha Boni, who left us very early. She was a dedicated nephrologist into pediatric nephrology. She was associated with Kashi sir. Thank you very much.